Hi, my name is Anime, and I will be presenting with my fellow classmates Madison and Sarah. Today we'll be talking to you about the current application and suggested protocol for deep infiltrating endometriosis, particularly with the use of transvaginal sonography. First off, let's start by describing deep infiltrating endometriosis, which we'll refer to as DIE for the rest of our presentation. As many of you already know, endometriosis is characterized by the presence of endometrial tissue outside of the uterine cavity. It is a chronic disease that affects 5 to 15% of women during their reproductive years. DIE, however, is a form of endometriosis that penetrates through the peritoneum by more than 5 millimeters. Specifically, DIE affects 1 to 2% of women and can cause a profound effect on women's lives as it commonly causes dysmenorrhea, dyspareunia, pelvic pain, and infertility. For many women, the journey to a diagnosis can be extensive and filled with misdiagnoses. Currently, endometriosis is assessed based on clinical symptoms, patient history, in conjunction with imaging modalities such as ultrasound and MRI. These imaging modalities are used to confirm clinical suspicion and are useful tools in preoperative estimation of the size, location, and extent of DIE. In terms of elimination, DIE relies on laparoscopy. But why transvaginal sonography, or TVS? So the goal of our research was to highlight the integral role that TVS has in the diagnosis and management of patients presenting with DIE, especially when combined with a dedicated TVS protocol. TVS, as many of you already know, allows for dynamic assessment, is easily accessible, and has high effectiveness. But who said there was high effectiveness? To get a better understanding of the effectiveness of TVS in the diagnosis and management of DIE, we compared 5 different studies in terms of their percent sensitivity, specificity, and accuracy. As can be seen in this table that we constructed based on the 5 studies, TVS yields high results in sensitivity, specificity, accuracy, up to 98%, 100%, and 99% respectively. Due to these results, one would have a high confidence in the use of TVS. Now I'll let Madison tell you about TVS and MRI.
MRI is another modality used for the diagnosis and detection of DIE. However, in comparison, TVS is more cost-effective and has shorter exam times. The real-time assessment of TVS allows us to detect key information that may be missed by other modalities. For example, TVS is superior in detecting DIE nodules on bowel, whereas bowel peristalsis, causing blurring on MRI, may result in these nodules being missed. MRI has contraindications like metal implants or claustrophobia. So, what does it look like on TVS? The common appearance of DIE on sonography is a hyperechoic solid mass with or without bright foci or small cystic areas caused by hemorrhage. The border will often be ill-defined, representative of an infiltrative pattern. Figure 1 shows a transverse image of a small hyperechoic nodule near the insertion of the left uterosacral ligament. The location, shape, size, appearance, and distance to anatomical landmarks should be provided as it aids in detection and removal of said nodule during laparoscopy. These are 2 definitive features of bowel DIE. Figure 3 on the left shows a thinner section extending from the nodule. This is known as a comet tail sign. On the right shows a sagittal image of a hyperechoic nodule with irregular borders projecting into the bowel lumen. This is showing an Indian headdress sign. This is caused by invasion of ectopic cells into the muscularis propria. I'm going to show some cines demonstrating positive and negative sliding signs. This is something Sarah will further touch on. A positive sliding sign: when pressure is applied with a transvaginal probe, the posterior cervix slides relative or opposed to the anterior rectum. I'm going to play this one more time. A negative sliding sign: when pressure is applied with the transvaginal probe, the posterior cervix slides with the anterior rectum, not relative to it. I'll play that one more time. I'll pass it on to Sarah to talk about how to utilize these sliding signs in our suggested protocol for DIE.
So here it is. The sonographer is to start with an evaluation for evidence of endometriosis within the uterus and adnexa. Do we see adenomyosis or endometriomas? With dye extending beyond the peritoneum, nodules are then searched for systematically based on anatomic location within the anterior and posterior compartments. The sliding sign, as previously discussed by Madison, is included in this routine to note severity of inflammation and adhesions. Finally, tenderness-guided sonography is used to correlate patient pain and probe pressure to find site-specific tenderness. So where exactly are we looking when I say the anterior and posterior compartments? Well, I have a diagram here to hopefully make it a bit more clear. In the red, we have the anterior compartment. If you follow along with my mouse, we're specifically looking at this red dotted line, where we see the bladder wall, the anterior uterine serosa, and the insertion points of the round ligament. For the posterior compartment in green, we're looking along this purple and blue dotted line, where we'll find the rectovaginal septum, the posterior vaginal fornix, and the rectosigmoid colon. In summary, as my pals are discussing here, TVS should be regarded as the first-line imaging modality for dye, but it's important to remember that following a standardized protocol is required for success. To conclude, we chose this topic because we know people who are affected by endometriosis. We've already met patients who have described their struggle to be heard, acknowledged, and diagnosed. Years of being silenced and suffering are happening unnecessarily. As sonographers, we have the opportunity to change this, so let's. We would like to give attention to the references that we used in creating this presentation. On behalf of Anna Mae, Madison, and myself, I would like to thank you all for your attendance to our presentation. I would now like to open the floor to questions.